I am really excited to introduce our speaker today, Dr. Bonnie Morris. She will be sharing her slide deck when I am through introducing her, but she is really an expert in this field. And so Dr. Bonnie Morris is the Vice President of Navigation at the American Cancer Society, where she leads the strategy and implementation of national navigation programs, including ACS Cares, ACS Lion, and the Patient Navigation Initiative. With a multidisciplinary background spanning clinical nursing, epidemiology, and behavioral science, Dr. Morris focuses on integrating digital health and patient navigation to optimize cancer care delivery. Her work is dedicated to increasing equitable access to high-quality care by addressing patient, provider, and system-level barriers. She brings deep expertise in program development, research, and policy, making her a leading voice in the national conversation on care coordination and health equity. I'm going to turn it over to Dr. Morris now, and if you have questions during her presentation, please feel free to drop them in the chat.
Thanks so much, Megan, and thank you so much for the opportunity to be here with y'all today. I'm excited to be able to talk more about as I get my slides up. So, Megan, could you give me a thumbs up? You can see them.
Yep, looks good.
Great. So excited to be able to share about how together we can make patient navigation more accessible across the country through these new reimbursement opportunities and how we can just work together to take action on those. Let's see. Get this to go forward now. There we go. So we know the evidence is clear that patient navigation overcomes barriers to care, increases timely access to appropriate cancer care, and ultimately advances health equity. We've seen this in a variety of different ways, from increasing cancer screening rates, increasing quality of care and patient satisfaction, and then decreasing healthcare utilization, unplanned healthcare utilization, like hospitalizations and overall increasing quality of life. Yeah, unfortunately, until recent, there has not been a reliable pathway for sustainability of these critical services. And so this has meant then that patients have had limited or no navigation services depending on where you go. It has meant also that there's been an ongoing need to support navigation services through external funding or as an unreimbursed administrative cost. Can't tell you how many times where I had to write and apply for a grant to fund one specific navigator. So a breast screening navigator. So that was for a 2-year term or a 3-year term. And then when that expires, what do you do? How are you going to continue to maintain that position? And so then when practices are able to offer navigation, there's a wide variation in how navigators deliver services and then how they're ultimately how they're trained to support patients. So this leads to a very inconsistent experience for our patients, or also affects the availability. So where it is available, it can be very inconsistent and ultimately exacerbate cancer disparities. But fortunately, the 2024 physician fee schedule included new reimbursement services for addressing health-related social needs. These included the Community Health Integration Services Code, Social Determinants of Health Risk Assessment Codes, and Principal Illness Navigation Services Codes, so affectionately known as PIN. I also am going to talk a little bit about principal care management, PCM, which was from 2022. So just noting that there, but these collectively are the codes that we have to work with to be able to recognize and more sustainably support our critical navigation related services. So as an update, before I go into the nitty-gritty around around these codes, I did want to just preface the call and the discussion that with the upcoming calendar year 2026 physician fee schedule, there's no proposed changes to PIN, which is great. We wanted to wait to see. We were hoping that there weren't going to be any dramatic changes with CHI. There's been a shift from social determinants of health, that language, to then upstream drivers, which is potentially a broader term, though it's unclear. But so we're going to see what the final rule has on that. And then it has proposed to eliminate the SDOH code with the justification that the resources associated with this code are already included, are already accounted for in other codes like E&M visits, for example. So I'm also going to just lay the foundation with some key terms that CMS uses to help us talk through some of the eligibility requirements, for example, as we're going through these slides. So CMS uses some unifying terms like billing practitioner. So this is a physician or other healthcare provider with a license to provide medical services and who can bill for Medicare. They also use the term auxiliary personnel, which is someone acting under the supervision of the practitioner. These can be employees, at least employees, independent contractors, including community-based organizations, but they are not able to independently bill for the services that they provide. Um, oh, good. Okay. I'm going to try to keep an eye on the chat to see as questions come through. So, I will, if I see them, I'll address them along the way, but please just keep them coming and then I'll either get them along the way or after the talk. So with incident two, this is another term that's used to describe the way these codes are utilized. So these are services that are provided by our auxiliary personnel that are billed as part of the practitioner's billing. This means that these services are incident, but yet integral to the professional, the treating provider, the billing provider's services during diagnosis and treatment. And then general supervision, this just means that this service is provided under this billing practitioner's overall direction, but they don't have to be physically present when the services are rendered. So with that, we'll go to the next slide. So briefly on community health integration. This is one of the new codes as of 2024. It was designed to address unmet health-related social needs that affect diagnosis and treatment of the Medicare beneficiaries' health conditions. Focuses on trained non-clinical professional staff who are billing incident to the provider's work. And they're designed where you bill for the first 60 minutes within a calendar month using the G0019 code. And then you can stack on additional 30-minute increments within that calendar month using the G0022 code. So this is the same mechanism or same structure as PIN code. So I'll talk more about that as we go along. With principal care management, this is the one that has been in existence since 2022, but we haven't seen it as robustly utilized. So I wanted to make sure we included it here so that we can have more uptake on it. It's care management for patients with one complex chronic condition expected to last 3 months or until death and places the patient at significant risk for high healthcare utilization. It requires the creation or update of a care plan and frequent adjustments to medication regimens or management due to complex comorbidities. Importantly, it is the auxiliary personnel is someone who's a licensed staff member, so a nurse or a licensed social worker. And so this is unique to PCM that you'll see is different from CHI or PIN, where there is not that requirement for a licensed professional. So we see this PCM code as being supporting the clinical care management, whereas we see PIN and CHI as the non-clinical care support within the use of these codes. And I have a figure to help illustrate that along the way. But the other difference here is that you can also have the billing practitioner bill directly through this or auxiliary staff billing incident too. And there's a breakdown for 30-minute increment and 60-minute or an additional 30-minute increment. So it's a little bit different also in the way it's paid out. With principal illness navigation, which is where we're going to spend the majority of our time today, these are codes focused on the non-clinical navigation and the treatment of a serious high-risk condition, specifically addressing health-related social needs and other factors that influence treatment outcomes. It is available for use both by hospital-based outpatient facilities and non-facilities. Um, Although this was originally a challenge and it still remains a challenge with PCM. But when these codes first came out, it was not specifically stated that within the CMS physician fee schedule final rule, and they later had an updated FAQ to spell this out. So if you are uh, unsure about that, you have to find both of those documents to be able to see that full picture. The other update that's been made in the 2025 rule was that it specifically stated licensed clinical social workers are included as auxiliary personnel. They cannot bill directly for this using this code, while they can bill directly for other care management processes. This PIN is specifically these social workers are specifically listed as auxiliary personnel incident with their services being rendered incident to the billing practitioner. So how can this work if we were going to then have a wider view of being able to maximize our reimbursement opportunities? Because ultimately that's what we're trying to be able to elevate these roles by showing that we can receive reimbursement for these critical services. So that's a lot of the reasons why I talk about these so much is because we want to have a clear pathway for demonstrating ROI for these services and being able to grow navigation programs. So we look at it in this overlay of a person coming in for a medical visit. There's an SDOH assessment done, regardless of whether or not that SDOH assessment has a reimbursement component built as part of the E&M visit, is what we're saying now with this proposed upcoming rule. But then there's determined either this first pathway that there's a serious medical illness, and then from that conversation, it's determined, well, do they have non-clinical needs? Well, then that can fall under PIN services. Do they have clinical needs? Well, that can fall under PCM services. And so that helps kind of paint the picture of how both of those codes could be used in the setting of a serious medical condition. If it's determined that there's SDOH needs only, I say only, but without the serious medical illness and qualifications around that, then community health integration is a code that can still be leveraged and used to reimburse for the services and the care coordination needed to be able to support that patient. So, in thinking about what is then the eligibility for PIN and for this also applies to CHI, but for PIN services, as I said, it's an illness that's expected to last at least 3 months, places the patient at high risk for healthcare utilization like hospitalization, um, acute exacerbation, functional decline, or ultimately death, requires a disease-specific care plan that may require frequent adjustment in medication or treatment regimens. Um, and then, importantly, cancer was specifically identified as appropriate for PIN in the final rule. And it's also relevant that we say that it's not that a cancer has to already been diagnosed. It's that it can be part of the workup leading up to a diagnosis. So a mass likely to be cancer that's in the process of being worked up can still qualify as a serious illness, allowing the initiation of PIN services. Is this only for cancer navigation and for other diseases? Great question. It is not just for cancer, it's for anything that qualifies as a serious medical condition. Did I go? No, okay. But since for the American Cancer Society, I'm speaking of it in the frame of reference as for cancer navigation. Great question. So who can provide PIN services? CMS was specific to say that PIN services should be performed by someone who's certified or trained um, as the auxiliary personnel that is then providing the professional services incident to and under the general supervision of the billing practitioner. The certified or trained, they did also include a list of requirements that go within that. And then it did state that it could include patient navigators, certified peer specialists, could be someone or it could be a group, a third party who has a contract with the place providing the services. So a CBO then has the opportunity to contract with a healthcare provider and so assuming that there's sufficient clinical integration to be able to demonstrate that relationship, although it did specify that CBO must be a not-for-profit. And so these activities that are then provided by a certified or trained navigator include the following activities, which is also then what CMS specified that the auxiliary personnel should be trained on. So things that peer support or navigators or community health workers are very common or very see very commonly are used to doing these person-centered assessments, community-based care coordination, health education, building self-advocacy skills, healthcare access or health system navigation, facilitating behavior change, facilitating and providing social emotional support, and leveraging the knowledge of the high-risk condition and lived experience when applicable. So all these things are what can then go towards counting for qualifying minutes of reimbursement. So again, I was saying with the G0023 code, is for the first 60 minutes of care in that calendar month, and then 30 minutes of care beyond that. So, is there a maximum number of hours that can be billed for PIN services in a given month? So technically, no. So there's no cap. CMS did not specify a cap on it on the number of hours or the number of times you could layer that 30-minute code. But practically, we've seen from organizations that have exceeded, I believe it was 4 hours, although I'd have to double check that number, that they have seen that it will get automatically kicked back, but then as a potential error, basically. And then they submit an exception to show, this was actually the amount of time we spent, and then it moves through the system. So overarchingly, the answer is no, there's no maximum. But in some cases where it exceeds what the system would expect when you submit the bill, that then it might require a little bit additional paperwork to be able to get it through. Hopefully that helps answer. Um, there's a cap on managed Medicare to 12 hours a week, but traditional. So that has not been for PIN payments. So then before PIN services can begin billing, we need to have this initiating visit. That's where the treatment plan is said. It's identified that the patient is eligible for as a with a qualifying medical condition. These are typically E&M visits for in the oncology space, and it's where they establish medical necessity and develop a treatment plan for care. PIN services can then be provided in person, by telephone, um, by synchronous. So you can have remote calls or by email or patient portal message. So there really wasn't a limit around how PIN services could be provided to then count towards this reimbursement. While these are averages, what we're seeing is for the first 60-minute code, we're seeing reimbursement in the range of $80 an hour for non-facilities and about $50 for facility payments. And then the associated potential cost sharing should the patient not have additional coverage would be $16 for non-facility or 10 for facility. And then the additional 30-minute codes reimbursing at $50 and $35 as an average. What we're seeing is that also non-CMS payers have some of them have been reimbursing at higher rates, which is where we're getting this range. So that's been interesting to see as well. As far as documentation goes, while CMS was not specific in what is needed for documentation, they did state that it is reasonable to then say that we want the total time spent providing PIN services. This is how you then are able to determine what you're reimbursed for, and then connecting it to the activities that the auxiliary personnel provided, as well as how it relates to the treatment plan and any SOH needs that have been identified. No maximums have currently been set. We were talking about that. Um, again, practically, there can be some back and forth needed, but there's also not been a maximum duration of providing PIN services. Although importantly, consent is required at least once a year or anytime the billing practitioner is changed. Uh, then also just practically speaking, if 60 minutes has not been met within a month, you just don't bill. But if you meet 60 minutes or more in the next month, you bill for those services. So I wanted to give a few examples then. So say, for example, we have Maria, who is a 68-year-old woman who was diagnosed with small cell lung cancer. She met with her oncologist, Dr. Smith, who's preparing Maria's treatment plan. Maria expressed concern with paying for treatment. So Dr. Smith recommends that Maria meets with Paul to then assess and address Maria's concerns. In this case, this is an example of someone who's a trained financial navigator. So, say, for example, that initiating visit occurs on December 2nd, where Dr. Smith and Maria discuss treatment planning, navigation consent is obtained, and the referral for connecting her with Paul occurs. Paul then has a face-to-face conversation with Maria where he does a person-centered assessment and makes referrals and assistance as appropriate. All in all, that totals 45 minutes. Paul documents that visit. He then, on December 10th, calls Maria to assess for any ongoing or new needs and assistance. And then that takes about 20 minutes and he documents the call. Dr. Smith is then able to attest that the CMS requirements were met for the eligibility around the serious medical condition and the auxiliary personnel. And so then the practice is able to submit the G0023 code using Dr. Smith's NPI since we met the minimum amount of the 60 minutes needed for that one calendar month. If then in that month, maybe December 20th, there was additional 30 minutes of time, they could submit the G0024 code to be able to also be reimbursed for that time. As a second example, we have Kayla, who's a 36-year-old woman newly diagnosed with breast cancer. They're preparing Kayla's treatment plan with Dr. Jones, but she expresses several non-clinical concerns. So Dr. Jones's medical assistant, Trina, who's been trained in navigation competencies and meets CMS requirements, meets with Kayla and then refers her to Michelle, a billing specialist. So here are two other types of support that could be providing PIN services. So say this initiating visits on November 19th, again with that treatment planning, consent, and referral, a face-to-face visit with Trina, who then spends 20 minutes and documents her visit with having done a person-centered assessment and referral. And then with Kayla and Michelle, where financial concerns are reviewed to discuss around how to optimize our health insurance and support prescription costs. That's a 45-minute conversation that then Michelle documents. Again, we see that we need that 60 minutes, although they're from different people providing navigation support, and they're not specifically called, have the title of navigator. They meet the CMS requirements for being trained in these navigation competencies. They're overall, the practice is able to submit for G00023. So, I know that was a lot that I just went through. I did want to also share that because we recognize this is a challenge, we developed the American Cancer Society Leadership in Oncology Navigation Program that seeks to champion and advance standardized training, credentialing, and implementation support. Much like what I'm doing right now, I want to be able to share, and our team wants to be able to share and educate on how we can get navigation to more people. So, for example, we have a training and credentialing part of our ACS Lion program where we provide foundational knowledge and core competencies around navigation to support being able to reimburse for CMS for PIN and in alignment with the oncology navigation standards of practice. That's once you go through 10 modules, you receive and take a summative assessment, you receive an ACS Lion credential. We have specialty certificates to continue to build upon navigation and care coordination knowledge, including one around clinical trials navigation. And then this upcoming year, we'll release one on supportive and palliative care. We also have continuing education to be able to, again, keep advancing knowledge and stay abreast of the changing landscape in oncology. In addition to that, so these are all on the individual support level. From a programmatic support level, we have learning collaboratives where we engage organizations to be able to support robust navigation, boot camps designed to help make the case for navigation and either starting or extending your program, resources, FAQs, regularly scheduled webinars, all things designed to help with the uptake and support of navigation. So, with that, I'll end it with some various QR codes with our fancy slide where you can access an FAQ on PIN. You can watch previously recorded webinars. You can get our business case for navigation toolkit or just explore the ACS Lion website to see what might benefit you the most. And I'm going to,
Yeah, I can ask the questions and thank you, Dr. Morris, first of all, for the
yeah.
information. And I can go through some of the questions that came in the chat. I know you were answering some of them through your presentation, but a few came in as you were starting to wrap up. So how does CMS confirm the actual PIN assessments for reimbursement?
How does CMS confirm PIN assessments? So what we have to do is to be able to, as with any services that are then reimbursed, be prepared if the organization's audited. So there's not a proactive CMS coming around and checking to make sure that these navigation services were rendered to patient X. But there's documentation that should be um, saved and made available should the organization be audited. Let me know if that,
Okay, Kimberly, hopefully that answered your
yeah.
question. And others feel free to keep putting questions in the chat or raise your hand if you want to come off mute, and I'll ask the other questions that came in. Can you share who some of the non-CMS payers are?
Yeah, we've seen across the board, and I don't have a list of them in front of me, but Um, uh, I think it was there even been some Medicaids that are some specific Medicaid. I think it was in Maryland. Um, I want to say Blue Cross Blue Shield. I'd rather give an actual list though, rather
Hmm.
than guess if that's something that we could send out afterwards. Would that
Sure.
be okay?
Yeah.
Okay.
Yep. And then Abby asked on slide 18, you're talking about hitting the 60-minute threshold for PIN or CHI to be able to bill. I know you said if you don't hit the threshold in a month, you cannot bill, but did I hear you say you can bill those minutes the following month?
Sorry, that was confusing. No, it resets. The clock resets each month. So they don't carry over.
Okay. Is there anybody who would like to come off mute? Just raise your hand on the react button at the bottom there, and we can ask your question. I'll ask a question while we wait. What are some of the biggest barriers to implementing the PIN codes or the PCM
Yeah.
in community settings?
Yeah, I mean, I think it's complex. Most of us weren't trained in billing and coding. And yeah, that's what's required to be able to start leveraging these codes. So you have to gather your key groups. You have to say, okay, who's my billing and coding champion? Who's my revenue cycle champion? Who's my clinical champion? Who's my navigator champion? Who's my EMR? My whatever electronic platform that you're using, who's that champion? And bring them together. And, that takes time and coordination. We've seen from the National Navigation Roundtable's certain recent survey that 20% of the survey respondents have started billing for PIN across the country, but 40% are in preparation. So that is recognizing that it just takes time. So as these organizations see that this is going to be beneficial, it then people are working through that process.
Okay. A couple other questions came in the chat.
Yeah.
So independent patient health advocate, which I think a lot of the advocates on the call are, would an advocate send a bill to a practice?
You'd need to have that established um, clinical integration, and that's most easily recognized through a contract. And that contract could spell out how you see this opportunity that they could be reimbursed for PIN or CHI or other pieces, other codes that then your services would support. So that gives justification. It's like you're then demonstrating your value to them because hey, you can basically have pay for my services by through this reimbursement.
Beth, did you want to ask your question?
Yeah, this is so interesting to me, but I'm curious I mean, are providers required to, I mean, if someone has the need for, this kind of, I call it billing services, are they required and are providers, um, embracing it? Because it's a very complicated
Mhm.
billing system.
Yeah, so what we've seen is 60% of our survey respondents are either billing or actively trying to implement billing. But I think you're also getting at, are they still providing navigation even if they're not billing? And the answer is yes. What we're seeing is that you can still provide navigation even if you're not billing. It's not a one or the other. And importantly, if a patient chooses not to consent, they're not consenting, they're choosing not to consent to the billing of the service, not the service itself. And so you can still, what we've seen is that you can still provide navigation services even if a patient doesn't consent, which is critical because what we want is for everyone to receive navigation that wants and needs it, not for then people who are at most risk to then not be able to have it because they can't afford it or can't afford that copay, that potential copay.
Thanks.
Mhm.
Couple other questions from the chat. I understand that only one provider can bill PIN or CHI per month. Is there a way to see if another provider is already billing these? And
Mhm.
could one provider bill PIN while a separate bills CHI?
Yeah, that's a great question. So, you're correct. Only one provider per specialty. So you have to have a treatment quarterback for oncology, for example, but you can also have a billing provider for PIN going through heart disease, for example. So you can bill for more than one type of chronic condition. Um, then you can also have separate bills for a billing practitioner for PIN and CHI. Um, I wish there was a way to understand like a national way to see if another provider, because what organizations have come back and said is, we can tell if our providers, because it's organizationally submitting for reimbursement, but what they can't tell is if there's another organization that's also billing for PIN for that patient for that disease. So we see patients that come in from a I'm from a rural area so our local community oncology practice, they're getting chemo and then they travel over to the big city, that big academic medical center for surgery or for radiation, for example. So then there's that potential that the community oncologist in that practice is billing PIN and also that academic medical center. And there's not, that I'm aware of, an easy way to be able to tell across practices. Um, so unfortunately.
Okay. Well, I just want to give a shout out to Teresa in the chat. She's answering a lot of people's questions, I
Oh,
think,
great.
as an independent advocate and sort of what she's seen and done. So thank you, Teresa, for that and for sharing your insights. I had another, Nicole or Dr. Rochester asked, does the supervising physician have to be the patient's healthcare provider?
They have to be the one responsible for the treatment plan.
Okay. And then the reimbursement rates seem low compared to the cost of billing. What has been the response of providers?
So the response that we've seen is that, well, I wasn't getting anything from it before. I might as well not leave money on the table. So even though it's not a huge amount, we have seen organizations, Texas Oncology, RJ Wood, so Barnabas Health, like organizations that have been able to show a pretty robust return on investment where they're getting enough to be able to then pay for positions for FTE in support. So it's not an insignificant amount by the time you add everything up and multiply it across all the patients you serve.
Okay. Are there any other questions? People want to raise their hand and come off mute or ask in the chat?
Bonnie, what was the requirement for a organization to be a not-for-profit?
That's for CBOs who partner with practices that are delivering the service to be able to be incident to or auxiliary personnel for them.
Okay. Okay, thank you.
Okay. Um, Folks are wanting to know if they can have access to your slides, Dr. Morris. I don't know if you're comfortable
Absolutely.
sharing them, but we could attach them in the follow-up, I think.
Yep, absolutely. And then any questions that I mentioned, let me just double check. I'm happy to like include that in that follow-up email. So the list of payers that we've seen, for example.
Okay. And then can you speak a little bit to like smaller clinics or independent physicians and their response? I recognize that you may not, I know you work mostly with larger clinics. So I don't know if you have feedback from like independent physicians or smaller clinics.
I think the challenge is actually it seems like, again, this is my observations, that smaller practices are able to be more nimble with being able to adjust their billing. than larger institutions where it feels like you uncover a new engaged person then you didn't realize needed to be engaged in the process every 10 minutes. And you're like, oh, okay, I need to bring them into the conversation and them into the conversation and to be able to move the process forward. So I'd actually say that it's probably a bit easier for smaller practices, but then there's also a trade-off because at some point they have to decide is the amount of time it would take to build this in worth than what I could get back. But what we've seen is that people still feel like it's valuable.
Okay. Any other questions?
I'm just curious, Bonnie, if you think or see on the horizon that this is going to dramatically change or grow or like what's maybe coming. I'm sure you don't have a crystal ball, but
I
just
wish I did, but I do think that this is a tremendous way for us to be able to sustain programs that support patients, like navigation programs that is no longer cyclical. It's not dependent on a grant cycle or one of the things. And as someone, I'm a former nurse, oncology nurse navigator coming from a health system where it seemed like anytime there were budget cuts that navigation programs were the first to go, or patient advocacy programs were slimmed down or strategically reduced. And you want to be able to move beyond that, and the best way to be able to do that is to be able to show a non-cyclical way to reimburse or to demonstrate value, and where you don't always want to tie it to money, but you can use that as a data point in addition to that whole big list that I shared of how we know navigation improves patient outcomes. Exactly. So we have that whole list, including reducing healthcare utilization and improving quality of life. So it's really speaking the language that's going to be have the most resonance with your C-suite or the powers that be to fund your programs, or fund your services if you're independent, because maybe they don't care about their reimbursement as much as these other patient outcomes, and you just titrate then your presentation based on that. But if you have that data, then you can use both.
Okay. I'm not seeing any questions. I'll give a second just in case somebody wants to raise their hand. But thank you. Hopefully everybody is coming away with a little bit of a clearer understanding of PIN codes. And I know it's confusing and that this was a topic that people wanted. So thank you, Dr. Morris, for joining us. If you can get your slides to me, then Chloe can make sure we get those out to everybody who registered so that you have them on site. I especially liked the sample workflows. I thought that was very helpful. So thank you. And thank you everybody for joining the community conversation today. And we'll see you at our next one.
yes, and the next one is on AI in healthcare in December, so make sure you look for that.
Yes.
Another
Excellent.
interesting topic.
Yep.
Thank you,
Thank you,
Dr.
everybody.